Okay, test. Hello, good afternoon, everyone. We are about to start. Hello. Good afternoon. Welcome, everybody, to this session. Good afternoon. Hello. Thank you. I know there will be a few more people on their way, so when they come, they can obviously join us. Also, good afternoon, good morning, and good evening, people online watching us live. So thanks for this session. I will take you through a few rules, obviously. So I think, as I mentioned, this session is going to be live streamed. And I think specifically in terms of the session breaks, when we have breakout sessions and so on, apart from that, everything will be live. And unfortunately, people online, we don't have the facility where you could ask questions or send us reminders and all of that, or even speak. So I think what we will do is, if there are any follow-up points you would like to know or discuss on this exciting Geshiyaro project, we are very happy to get back to you on those things. So I think for people who are in the room, please take a look at the instructions for in terms of exits, fire exits, and all these procedures which we have been briefed in the morning as well. So my name is Dr. Miratab Salasbo. I am the director for the Evidence Measurement and Evaluation team at CIF, Children's Investment Fund Foundation, based in London, and I'm one of the team members who has been leading this evaluation project for the past 5 years. So before I go into details, and we have wonderful presenters here lined up to take you through the journey in this Geshiyaro project. So I will not talk too much so that I give them more chance to them. But just to say a few things for context purpose. As you all know, I think especially around 5 years ago when this project started, the discussion was in terms of how long do we continue doing mass drug administrations. Do we need to change strategy? Do we need to think about actually interrupting the transmission break, especially in STH and SCH? So there were a number of discussions around, and this is a time when the Geshiyaro project started. So as you know, there are other initiatives, obviously specifically DWORM 3 at that time, but in terms of community-based quasi-experimental study, to test whether we would be able to achieve interruption of STH and STH transmission. This was kind of a unique project. Before I go into details, obviously, just want to mention a few points. What was unique about this project in terms of what was being tested is, for example, treatment of MDS twice a year versus once a year, and also verification of the interventions. And also there was wash intervention embedded within the intervention as well. So there were a number of innovative solutions that were implemented, and you will get to see the results in a series of presentations. So I will not go into detail into this. So that's the map which shows Walaita region in southern nation in Ethiopia. So this is a place where it has around 2.2 million population. We selected 2 arms from this zone in Ethiopia, in Walaita, and then there was a third one outside the region as well to compare all the innovative areas I mentioned earlier. And then I think specifically, as I mentioned already in my intro, in Arm 1, we wanted to test, let's treat all the community. Rather than school-based, let's treat everybody, all adults, and then added wash intervention as well, which you will get to hear. The second arm was only community-wide MDA, but we followed the government national wash program that was being implemented in the country. And the third arm, we continued using the school-based MDA, which has been going on for a number of years, also the government standard wash intervention as well. So that's the kind of design we had. What did we aim to measure? Obviously, as I mentioned earlier, when we planned about interruption of, trying to demonstrate interruption of STH transmission, we had to set targets, and there were papers from modeling that were set at that time. So the aim was to achieve under 2 prevalence, and of course achieve coverage, 90% coverage in terms of the MDA treatment, provide access, especially in Arm 1, I described earlier, access to water, 85%, sanitation, and of course 100% ODF. These were specific objectives that were laid out per each arm when we designed this project. So as you can imagine, it's a big community-based project, so there were a series of data collection that we have been collecting over the last 5 years. So we have MDAs. When MDA is happening, there is data we collect by identifying the individuals. First, it's through a census, and then when they come for MDA treatment, we verify it's the same people, and then we give them the medication, obviously. So we have a database on that. We also track the MDA coverage using the WHO standard survey, which you will get to hear again the results later on from my colleagues. We also collect in terms of WASH interventions. We have parasitological mapping using our sentinel sites, which again you will get to hear later on from the team, and related interventions. So without taking too much time, because you will go through each one of them in this session today, I'm going to invite colleagues now one by one to come and present the sessions. Before I do that, I just want to acknowledge the Ethiopian government, specifically the minister, Dr. Liat Adese, the state minister, Dr. Dereje Duguma, and of course EPH, our key partner, Dr. Getachew, who is actually within us now, and Dr. Garama for their support when we designed this project from the beginning. So thank you very much. And I will now invite the first presentation, Fikra from the Federal Ministry of Health. Over to you.
Hello, everyone, and good afternoon. Welcome to the Geshiyaro session. So my name is Fikra. I'm the National Entry Program Manager and Minister of Health, Ethiopia. So today I will take you through a very short presentation that shows how MDA MDA intervention was going for the Geshiyaro project that Dr. Murata was talking about. So I will talk a little bit on the modalities of MDA delivery and what is house-to-house MDA and the Geshiyaro house-to-house experience, specifically advantages and disadvantages of house-to-house MDA for NTD, and what were the challenges that we encounter while doing the house-to-house MDA. As you know, there are certain MDA delivery platforms. The first one is a school-based platform, especially if our program is targeting only school-age children. So the school-based platform is the best choice for the MDA. And the other one is fixed point. This is usually common for community-based MDA, where a fixed point is identified with the community and MDA is being delivered. So we are particularly doing this for a number of MDAs like onco, trachoma, and so on. And there may be also fixed mobile, which is a kind of combination, and the other one is house-to-house. This one is our interest for today's session. So what is house-to-house? This is a scenario where drug distributors are supposed to visit each and every household under the target's catchment population. And this will give us a special opportunity for delivering health education during their house-to-house visits for household members. And this will help us to reach each and every community members in that target area. So how we reached into the decision to use house-to-house MDA. The first one was, as you know, there was a COVID pandemic in early 2022, and it was challenging to deliver community-based interventions, especially MDA, where there is a mass gathering. So with using the WHO guidance, we were forced to develop a kind of mitigation strategy. So as you can see here, we developed a standard operative procedure that can guide MDA distributors and program managers to do the MDA within the COVID pandemic. So during that, the strategy development, we identified moving using door-to-door MDA delivery as a best strategy to reduce unnecessary COVID introduction into the community, as well as achieving a maximum coverage. And the other one is we also tried to learn experiences from other health programs that have the same service delivery platform, like immunization, nutrition screening, and many others. And of course, even trichiasis suspect identification and so on. So we came across with a consensus to treat the community by moving to door to door. So if we try to compare the two initial project years, year 1 and year 2, where we piloted the project only in one district, we used the school-based platform for the 2 years, and then right after the COVID pandemic in 2020, and we expanded the treatment target groups into 22 districts. So if we tried to compare the result of the coverage from school-based to from community-wide drug distribution to house, as you can see, during the first 2 years, we were not able to achieve even 75%. In the 2 years, our coverage, the first year was 77, and the other year it was 74. So in this case, we were targeting the whole community who are living in that particular district, but we tried our best to reach, our target was 90%, but we were not able to reach to 90%. And after moving to house-to-house MDA delivery, as you can see, for the 3 consecutive years, we were able to reach either more than 80%. So maybe as an advantage, if we, as an advantage, there is no mass gathering, as I said, and this is, we were able to avoid any COVID introduction to the community and for the MDA team as well. And this is very advisable strategy to reach each and every household within the community. It's an appropriate for health education message and to deliver other health service programs. And it will give us an opportunity to integrate other health services, as I said. And for example, household assessment for the hygiene and sanitation and so on. As an example, during MDA house-to-house visit, health extension workers, those are people who deliver the MDA, and they were able to test malaria suspect cases. They carry the malaria diagnostic test kit along with their MDA logistics. So, for example, in one of the village, they were identified 10 suspect malaria cases, and out of this, 7 of them were turned positive for malaria falciparum, and this is the most recent experience. So it's very possible to integrate different health services during the house-to-house visits. Maybe coming to the general, it may take time because we are supposed to reach each and every household, and especially in rural areas where the households are very scattered, we need a number of, the MDA team should be calculated based on the household, number of household, as well as based on the number of people to be reached per day. So it may need additional team compared to the community-based drug distribution. And especially in urban areas, as you know, urban dwellers are usually their employers, and we can't find them in their house during the house-to-house visit. So a special MDA calendar or MDA launching is very important to have everyone in their house during the visit. So this is how we train, we deploy MDA supervisors and mentors during the MDA, prior to the MDA. So each and every district will train supervisors and mentors that can support the MDA team. So this is what I already said. Just if we consider house-to-house MDA as a strategy, so there should be an appropriate logistic management system. The duration of the MDA should be properly calculated, and the number of households should be properly identified, and the number of people should be also properly calculated before going to the MDA. Adequate number of supervisors and mentors should be in place. Thank you. If you have questions, I will be happy to respond. Thank you.
Thank you, Fikra, on behalf of the Ministry of Health. Now I will go to the next one. I mentioned innovation earlier. So one of the innovations was obviously biometrics technology, where we identify people and then we verify whether they have actually taken the drug or not. So to present this, and Simprints is one of our key partners in this project, working with EPH and Imperial. I will invite Melke to come and take us through this presentation, please.
Okay, thank you, Dr. Murtab, inviting me to present on the biometric part. Good afternoon, good morning with your respective time. So I will spend a few minutes on how we are going to use the novel biometric data capture in a large scale project. As Dr. Murtab earlier tried to explain, as we have 3 different types of arms, then we are going to use this biometric in one of the arms, that is in arm 1, and I will say a few points about this thing. So the goal is to develop a scalable, cost-effective model in terms of transmission break, which is going to be below 2%. So we will have different intervention mechanisms. The first one is mass drug administration, and the second one is extensive wash activities. And there will be also SBCC as well as ODEF. So in this respect, we will use the biometric data capture in 2 scenarios. One is in terms of reaching out individuals. At the first time, census was conducted, which is going to be capturing socio-demographic characteristics along with fingerprint of beneficiaries. And then later on, we will try to identify those beneficiaries for the MDA, as well as to trace the longitudinal as well as cross-section prevalence for the different types of STH and SSH species. So there is just lack of formal ID cards. Sometimes there can be difficult in terms of identifying individuals by using their name. So this biometric data capture is very important and helpful to trace individuals at the different time point activities. So we need to have this biometric identification at 2 points, like at the time of mass drug administration, as well as at the time of measuring or knowing whether they are being infected with a given STH species, so on. So what we need is only 2 physical apparatus, smartphone, as well as there is one more additional apparatus, that is the Vero scanner. And then we need to have 2 things. One is a digitized form, I think, which is common in every data collection scenario. But one additional thing in here is going to be the Simprints app ID. So when we take fingerprint of individuals, that picture will be converted into an alpha numeric text, as you can see here. Then later on, we will use this one by matching with the existing one and the currently taken fingerprint, whether they match or not, which is important to trace really the HEWs or anyone performing the activity is reaching out the intended beneficiary or individual. So in here, we are going to see some treatment coverage outcomes. We have reported coverage, and we have also the treatment coverage survey based on the WHO guideline. So we have biometric ORADAS and we have non-biometric ORADAS. So as you can see in here, the red ones are the non-biometric ORADAS, where we don't use this innovative biometric data capture. The black ones, as you can see in here, we have the reported coverage by the implementer, and we have the research survey coverage by the evaluators. And this column shows us the different in terms of percentage between the reported and the treatment coverage survey by the independent evaluators. So these are just the woredas or districts where there is no biometric data capture. But the red ones, as you can see, there is high difference between the reported by the implementer and the evaluated figures. So it ranges from 13 to 32% in terms of reported and treatment coverage without using this biometric data capture. But for the biometric data capture, I think, as you can see, it ranges from 0.8% to 5%, which is just showing us a great implication of introducing this biometric data capture or not. So this is going to be very important, really knowing whether the reported coverage and independently studied treatment coverage surveys are in hand or they are just apart. So as you can see, we have a very small difference for the biometric woredas, but there is just a large variation in the non-biometric woredas. And in here, of course, we also introduced a type of deduplication. This deduplication is important in terms of identifying duplicate records. So there can be just names which are similar, so that can be just difficult to really identify whether they belong to the same individual or not. IDs can be lost, so what we can keep at any time can be taking the fingerprint of individuals. So deduplication is performed, and 3 scenarios can be used. The first scenario is the average one, and this is just used during the activity. That's going to be identification. And the second one is the maximum. This is also important to identify whether there is a possible fraud using just one finger many times. And the third one is the min-max. This is also important in terms of if there is any switching of fingers by the HW or by any individual who is using this type of verification method. So these are just the different scenarios we use. This is at the actual activity we use for identification, and these ones are going to be used also to detect whether there is fraud in terms of due to user behavior problem, or it can be in terms of switching fingers at the different individuals. And we have also included the name education. We just provided 85% of the names from those local individuals and try to categorize whether those names belong to the same person or not. And then in conjunction with the previous one and this name education, we come up with a type of result. So as I said, there was census, and this is the census figures, and these are just the line list pre-deduplication. But from post-dep, as you can see, there are just 25% to 28% of deprecation rates. So from the existing records in this district, 25% are found to be duplicates. So this will have an issue of denominator, which will lower falsely the coverage figure. So the biometric is very important also in terms of knowing what's going to be approximately a normal denominator figure. So I think this is a very big gap in terms of figures before deduplication and after deduplication. So this is also the advantage of the biometric. So what are the challenges? The first challenge was community resistance. So this can be attached with due to different local behaviors, like just it can be 666 or satanic, etc. So this was a big challenge at the beginning. The other one, even resistance by the health extension workers. They assume it will take too much time. So they are not just interested to use this one also. The other was accidentally logging out and uninstalling the SimPrinters app. This is just related with motivational aspect of the HEWs. Also, there are just modules which contain the list of individuals during census, where it is going to identify a possible beneficiary. And they used to use wrong modules for a given work area, Also, they switch phone devices, which will have just a direct relation with exchanging also or having wrong module in phones. The other one is internet connectivity problem. It has to be synced or sent to the server. It has to sync also the modules, but connection issues are really a problem. The last one was different user behaviors. So as an individual, HEWs introduce different behaviors, intentionally or unintentionally. So these are just the remedial measures taken from year to year. Of course, it is improving in terms of user behavior, in terms of motive, in terms of resistance due to the delivery of sensitization and mobilization. The other one is train and build capacity of HEWs as well as health experts from the different Warada health sectors. We make HEWs to equip them and understand as the workflow is very simple, not to exaggerate as it is difficult and time-taking. Also, daily reports are generated and shared daily with supervisors, and also they follow up the HEWs. So they will follow HEWs with respect to the generated report, and also make sure every phone has the right or correct module. And lastly, what is introduced nowadays is uninstalling SIM printers is impossible as it is locked with password. They can't change modules, they can't uninstall the device as the application is password protected. So the advantage, it increases transparency and cost effectiveness, confirm really the pupils are reached out. And the last one, it helps us to identify duplicate records as I tried to show you on the previous table figure. Thank you.
Thank you so much, Melke. So that was obviously another innovation. In the interest of time, I'll rush quickly to the next one. I mentioned WASH program is also another program we tried integrating within the project in one arm. And to present this, I will invite Andreas from one of our very important partners in this project, World Vision. And Andreas led this from the beginning, from scratch, so we've never attempted this before, WASH with an NTD space. So Andreas, over to you.
Good afternoon, everyone. I think this instrument is not height friendly. Am I visible for everyone? Okay, so. Okay, so it's friendly. So integration of my presentation is about integrating WASH program into SCH, STH programming, you know. It has been actually the discussion point integrating WASH into NTD. This project demonstrated the possibility of integrating WASH programming to the NTD intervention, specifically STH and SSH. And this picture was taken, you know, during one of the water system inauguration or commissioning to the community. You see children are enjoying the water with happy face. So we can say that WASH is an important element of people's joy, specifically water and other WASH interventions. So the introduction part is already delivered by Dr. Maratab, so I directly go to the water intervention. So when we say water, okay, what kind of water, how much water is needed for the community per household, so that we design our WASH intervention or water intervention accordingly. As per WHO standard, each and every individual needs to get 25 liters of water per day within, actually, as a basic service level, within 30-minute round trip, including fetching and waiting time. So our target for this project, our target is 85% coverage, which means for over 300,000 population delivering enough quantity of water and enough quality of water or safe water for this much population in the 5 districts, which is the Arm 1 district. So upon the end of year 5, it's possible to reach these all communities with water access. And to come up with that, you know, we employed over 10 fully engaged civil and water workers, engineers working across on the water infrastructure, big capacity tankers to deliver enough water for communities ranging from 77 meter cube to 248 meter cube. And, you know, as promoting renewable energy in terms of pumping the water system, solar panels or solar powered systems installed, around 896 solar panels installed for the water supply systems using this 26 submersible pump, and 20 transformers from the national grid line installed to reach this 85% coverage in the Arm 1 districts. As you can see here, 344 kilometers of HDP pipe installed in the entire 5 districts, which is the Arm 1 districts, which means I was trying to calculate the distance from here, Chicago, to somewhere else, you know, city in the US. So if you can count, it's from here to Springfield, I think. So if you extend the HDP line from here, Chicago, it can reach up to Springfield. So this much amount of, you know, pipeline installed or reticulation system installed in the entire 5 districts. So as I said, the total population we reached through water is 275,000 population with a percentage coverage of 44.3. So from the baseline, we are able to push the water coverage by 44.3%. So delivering water is one thing, but making sure that that water system is delivering water the entire time is also another thing. So proper wash governance needs to be in place, which is one of our intervention, so that communities are managing their own water resource throughout time by you know, appropriate tariff system and appropriate governance and appropriate operation and maintenance. So this is actually the Ethiopian BUR. So in each and every district, this is a total amount of money collected for operation and maintenance, so that we provide the water, but the communities are the ones who are actually extending the water system functionality throughout time. The second important part of this intervention is sanitation. Providing water is one thing, that's very wonderful, but water only cannot actually solve our entire problem. Sanitation is very important. When we say sanitation, sanitation for households as well as sanitation for institutions. When we say institutions, healthcare facilities and the schools. So for the households, before we start the intervention, we studied the area and we found out that the communities are divided into 3 different parts. The above 50% who are able to pay for their own sanitation products, and the middle 70% here needs to be actually, there are community members whom they don't have actually disposable cash at the moment, but if we facilitate credit service, they can access, you know, sanitation products. And the below 50% with any means, they cannot actually afford to pay for their sanitation products. So the only way to address them is through subsidy. So for the 50%, which is the above 50% who are able to pay out of their pocket, we establish local solution for the local problem, which is local entrepreneurs, users who are actually, you know, producing those materials and products for the community. So this wash business centers producing sanitation facilities such as latrine, but not only latrine, they are producing soap for hygiene products. They are actually selling, retailing and selling shoes for hookworm, you know, hookworm prevention with affordable price for the communities. So this is actually addressing these communities. Again, with the wash business centers linking with microfinance institutions, addressing the middle 70%. Microfinance institutions are designed to address the lower level of communities and households. So by engaging microfinances, enabling those households to buy their own sanitation products, and the below 50% addressed by subsidy. So the project procured over 40,000 slabs and it's under distribution. Just to show you the figure, these are the total amount of slabs sold for a community is 26,000, and this is 134,000 liters of soap already sold for the communities. As I said, the second part is institutional wash, When we say institutional wash, I said health facilities and educational facilities. For sanitation intervention, we focus on educational facilities because schools are the place where children are spending considerable time out of their 24 hours. So these schools need to get proper sanitation facilities like this one. And like this one, the handwashing facilities. So we constructed 37 sex-separated or gender-separated latrines throughout these 37 schools, which is 64 blocks of latrines in the entire 4 districts. Not only the physical structure, but also awareness creation with social behavioral change communication and capacity building. And 36 health facilities, health centers, and health posts are connected with water. So this is actually the success of WASH business. So this WASH intervention is, the learning is not only for the WASH-NTD integration, the learning is for the WASH sector itself, because lots of innovative things are already embedded in this implementation. The last but not least, we all know about social behavioral change communication. We always talk about it, but when it comes to the actual implementation, it's very difficult. In our local saying, in Ethiopia saying, there is a musical instrument which we call it kabaro. When it is actually in the hand of a trained person, it's like actually, it's like easy, but when you bring it to yourself to try it, that's very difficult, So in Amharic, kabaro በሰው እጅ ያምር ሲይዙት ያደናግር. Those Amharic speaking people are very well understand the local saying. So this SCBCC intervention is like that, When we designed it, it's very simple and it can be implemented anywhere. But when it comes to the actual implementation, it's very difficult in terms of monitoring, in terms of handling the intervention. So in this project, we developed its own strategy to implement social behavioral change communication for schistosomiasis and soil transmitted helminthiasis, and we coupled the difficult part of social behavioral change communication, which is interpersonal communication, with mass communication. Mass communication is very easy. People can, design and implement it in a very easy way through radios, through town criers, through different materials, printed materials. But interpersonal communication needs day-to-day engagement with each and every individual. So the strategy rolled out in 4 major implementation pillars. These are actually using a surround sound effect approach, the health system approach, the school-based approach, mass communication, and phase leaders engagement approach. So the surround sound effect approach means you can find the household in all directions. Even though the household members are sitting in their home, you address through the health system, which is the health extension workers. Students are going to school, you address with the school system. These households are going to the, these institutions, religious institutions, you address through phase leaders. And if they are going to the market and open places, we address them with mass communication. So in the health system approach, we are using the existing health extension program in the country. So 35 households in one, there is one coordinator for households, and 30 households under one coordinator. And this is cascading model, goes up to the SCBCC manager of the project. So the message delivered through this all platform until it reached to the household. So as per our assessment, households' knowledge toward this disease transmission related to poor handwashing practice, in the 5 districts, as you can see, in Boloso Bombe, 100% of communities are associating poor handwashing practice with ascaris, and in Damosori, 90, 82, 61, and 52. The same holds true for diarrhea and other diseases. And health development army's confirmation over households practicing with their members after interpersonal communication. As you can see, 98% of households are, confirmed they are practicing hand washing throughout the time. The second one is a school-based approach. So students are in the school. We need to address them through edutainment, which means education through entertainment. So we come up with a very innovative way of delivering our message, which is virtual reality. We are on the digitalization era, so we developed these 360 videos for the school kids. When they see that video, you know, how hookworm is penetrating our skin, how it goes to our body. When they, you know, get in contact with that video, you know, the result is very actually commendable. A school tournament like this one, it was supposed to be football, but you know, just to minimize those operational costs, we changed it to running because Ethiopia is, you know, the runner country. So athletics is very common in Ethiopia, so we changed it to running. So the mass crowd are conveyed message through that platform. And comic book for children's and school wash club establishment. You know, 75% of students, after they exposed to this VR video, able to associate schistosomiasis directly with hookworm, and 68% of students associating schistosomiasis with avoiding freshwater contact. This is mass communication. As you can see, the picture here, as the mass gathering, and the mass gathering, we are promoting the behaviors that we want to achieve in the communities using brand ambassadors, musicians as well. And the last one is faith leaders, you know, using customized wide-sensitive religious leaders manual with Bible. You know, the operation area, most of the operation area, our operation area, Christians. So we develop messages as per Bible stories so that these pastors, church leaders, preparing sermons as per this manual and delivering message for the communities. And this is actually the number of religious leaders and institutions receiving the training. Thank you so much.
Thank you, Andreas. Thank you so much. I think you switched to running after Ethiopia left the African football. Because at that time, I think when we started, we passed to play in the African Cup. Right, okay. So I will now swiftly move into the next one. So with this one, now we have seen obviously the MDA, we have seen the verification biometrics, and we just saw the WASH as well, basically linking with the hypothesis that WASH plus NTD is the way to go. You know, that's what we try to test here. Now, we wanted to see exactly what was the coverage in terms of MDA, and there are standards obviously by WHO as well, so we applied that. And to present, I will invite Dr. Onatu to show us what the results were. Thank you.
Okay. Thank you, Miratab. Good afternoon, everyone. So I think I will be presenting on the treatment coverage. I think the first presenter tried to explain about the reported coverage, which has a lot of known limitations, and we cannot take that as a final coverage by either WHO or by our Geshiyaro project. So we need to verify the reported coverage using reported coverage rates that are directly taken from the WHO. So I'll try to have this presentation outlines. I'll try to have the introduction, the quality assurance, the key findings, the conclusion, and the priority actions. So as you all know, the neglected tropical diseases are a group of infectious diseases that affect around 1.4 million people. Among the NTDs, schisto and STH, in which the Geshiyaro project mainly focuses on, are common and they affect people who live in poverty, especially in developing countries. And there are lots of preventive, there are lots of methods that we can control and treat these NTDs. And as you hear from the previous presenters, WASH is one of it, and the other one is the preventive chemotherapy. So the treatment coverage evaluation surveys, as part of any evaluation activities for any drugs, treatment coverage evaluation surveys are very important. They can tell us the precise statistical estimates that can probably undermine routine reported coverage. So Fikra tried to present the reported coverage. Obviously, there are lots of issues with them. So we have to validate those reported coverages using the coverage evaluation surveys. Quality assurance is very important during our survey. So we have been doing this since 2020. So every year after each round of MDA, we will conduct the post-MDA coverage surveys in order to monitor the progress of the program. So as part of the quality assurance, we have tried to use the WHO coverage survey the tool that's designed by or that's recommended by the World Health Organizations, and this will avoid the measurement error. We adapted directly the WHO protocol for the meter part as well as to generate the report, and this is the standard to be used by WHO. So we used it to generate the daily reports or the error reports, and we communicate daily to the field team because we are collecting data electronically, either using the phones or the scanners. So we generate the reports every day, and at the first day of the next day of the data collection, every data collector should have the error reports so that they can correct any errors on site. So there was a strong training and supervisions to be conducted by a lot of teams, experienced teams from the field teams. In order to avoid a recall bias is one of the biggest issue during the post-MDA coverage surveys. Participants may not recall which drugs they took or not. So it's highly recommended to do all post-MDA coverage surveys immediately after the MDA. So in majority of the cases, we have been doing the post-MDA coverage surveys just after the end of the MDA. So starting from 1 week to 1 month. So that will avoid the overall bias. We used the calculated sample size so that there will be a very precise estimate which can tell us about what the coverage looks like at the Kabali level and at the Warada level as well. The other one is the experienced data collectors. This all increases the quality of the data. So we have tried to have a figure for the last 3 years trained. So this is the percentage of individuals who swallowed the drugs, or this is what we call the survey coverage per our definition. So it shows an increasing trend from 2021 to 2023. So this is a very good news to break the transmission of schisto-STH. Every year, the number of participants swallowing the drug is increasing. This shows the reporter coverage. Okay. So this shows the reporter coverage. Usually, we are trying to compare the reporter coverage with that of the survey coverage. In case if there is a high coverage, a high reporter coverage, so it means that there may be some sort of inflation by the health extension worker or by the Ministry of Health, and that's not desired. The gap between the survey and the reporter coverage should be very narrow, and that shows that we have a very good reporting system implemented in place. So we expect the gap between the two to be very minimal. So if the reporter coverage is decreasing, it means it's a very good news again, pertaining to the reporting specifically with the health extension workers. This shows the percentage not offered the treatment. It shows a declining trend. So it means a lot of people are still taking, compared to the previous years, people are still swallowing the drugs. Still, we have around 10.82% who fail to take the drug. So we need to address these people because we need to have greater than 90% coverage, but we need everyone to swallow the drugs to break the transmission of schisto-STH. So we have tried to capture some of the reasons why participants are not swallowing the drugs, and these are the common reasons mentioned by majority of the participants. And beneficiaries absenteeism during the MDA, this was the greatest reason for not offering the drugs. So they will be absent. We'll provide the drug in majority of the cases house-to-house strategy. We employ a house-to-house strategy, but at that time, people may not be available at their home. So these are mentioned by majority of the participants. Drug distributing failing to reach to all householders. It may be due to topography and other reasons. The health extension workers will not reach to the participant's household for many reasons, including probably the motivation of the health extension workers. Beneficiaries not informed of the programs. Some beneficiaries will not know about whether there is MDA or not, despite repeated rounds of MDA. So we need to address these issues. Pregnancy, of course, there are some restrictions where WHO clearly indicated not to provide the drugs. So pregnancy was the major reasons. Across years, we have a similar reason mentioned by the participants. So it means that I think we need to address every year, because if the reasons are the same, then they should be addressed, and we don't expect the same reason to happen year after year, okay? So probably Ministry of Health, FICRA, will need to figure out those reasons and work on those reasons. Usually lower coverage in urban town. We observed a lower coverage in urban town compared to rural areas. In rural areas, majority of the participants will take a drug, but in urban areas, as high as 25% of the participants will not take the drug. So we need to figure out why people are not taking drugs in urban areas. There is a huge gap between the urban and rural participants in drug uptake. So as a conclusion, better coverage figures compared to the last couple of years. That means we have an increasing trend in terms of coverage. And the Ministry of Health should keep this one going forward. We'll have additional 2 years and around 4 rounds of MDA, so we expect a higher coverage in the coming years. We need to strengthen our social mobilization, because there are people who don't know about the MDA, so we need to work on the social mobilization strategies. We need to change our social mobilization strategies, and we need to strengthen as well the available social strategies. A repeated visit by the health extension workers. People may not be available at the time of visit, but we need a repeated visit by the health extension worker, even if it is very challenging to have a repeated visit, but we encourage the health extension workers to do that. Motivation is one component of the increasing probably the coverage across years, okay? So separate strategy for urban and rural. Thank you.
Thank you, Dr. Onatu. So we have now just 2 more presentations left. So basically, what does all of this mean in terms of results? Remember, we started by talking about trying to demonstrate interruption of STH, SCH transmission. So how does the prevalence look like, especially in these longitudinal sites we track? So to answer that question, I invite Burhan and Dr. Zelalem from SIF. So this is the only presentation where we have 2 people, so I leave it to them to manage themselves within 10 minutes. Over to you. So Burhan and Zelalem.
Hello everyone, my name is Zelalem. I am manager for evidence measurement and evaluation at SIF. So I and Burhan are going to present on the impact of the Geshiyaro intervention on 3 arms. So this is one of the evaluation activity which is related to monitoring the prevalence of STH and SCH in the 3 arms of the project. I think this is already mentioned. The goal of this program is to reduce prevalence below 2% for both STH and SCH, and the implementing partners are Ministry of Health and World Vision. So the Sentinel site is embedded in the program implementation, and it was being conducted by EPHI, Ethiopian Public Health Institute, and Imperial London College. So the purpose is to monitor the impact of our WASH activities, MDA, over time in terms of prevalence of schisto and STH. So in terms of methodology, we have 3 arms, and the interventions in arm 1, as it was explained, is we have expanded MDA for all age groups, and intensive WASH that Andreas presented. And the second arm is, of course, there is expanded MDA, but the WASH activity is an activity that is already existing. And in the third arm, the MDA is school-based MDA and national WASH program. So we have 45 sentinel sites in the 3 arms. In each of them, 15 sites of sentinel sites. And I think in terms of intervention, especially in arm 1, we have MDA, which was, I think, already explained by Fikra and others. We have the WASH targeting 85%, water coverage, 82% sanitation, and 100% open defecation free, and the SPCC part. So I will hand over to Brahan to present the result.
Thank you, Zelalem. I will continue where he stopped. So I think I'm going to present the reduction in schistosomiasis and STH prevalence and intensity at baseline and last follow-up survey. So as explained, the baseline was in 2018-19, and then the follow-up was in 2022-23. We have used different statistics to compare the STH prevalence and the intensity between the baseline and the follow-up, and then to compare the prevalence and the intensity among different arms. We have also calculated relative reduction, and we have also calculated difference in difference for different arms. So this slide is showing the participants enrolled in the longitudinal survey. For the purpose of this analysis, we have split arm 1 into 2. Arm 1 pilot, which has only 1 district, it started the implementation earlier than the other, and we considered it as a pilot. So you can see the number of participants in different arms is almost comparable. So this is the first result showing the reduction of STH in different arms. The line red here is showing the reduction in arm 3, which we consider control, and the line yellow is arm 1 pilot, and here is the arm 1. The blue line is showing the reduction in arm 2. So you can see there is a reduction in all the arms, and there is also significant reduction between the baseline and the follow-up survey. But as you can see, the relative reduction is very high in arm 1 and arm 2, but the reduction is very less in arm 3, which was implementing a school-based MDA. So even if there was intensive WASH intervention, okay, thank you. Just started, but remain 5 minutes. So, yeah, okay. Even if there was intensive WASH intervention in arm 1, there was comparable reduction in arm 2 and arm 1. So as you have heard, there was a standard WASH intervention in arm 2, but in arm 1 there was intensive intervention. But the relative reduction was comparable between these two arms. So this is just community-based MDA has a better impact overall to the STH prevalence than the school-based MD. So we have identified one species. So there are 3 species identified in this project site, but the dominant is Ascaris, and so we have selected Ascaris for this analysis. You can see there is a reduction in Ascaris prevalence in all the arms. Still, the relative reduction is much better in arm 1 and arm 2. There is a reduction in arm 3, but still to lesser extent, and suggesting that the community-wide MDA has also a better impact than the school-based MDA. So this slide is showing the frequency distribution of Ascaris egg count, indicating a very high aggregation and negative binomial distribution, meaning that so very few people have very large number of eggs, but majority of people having small number of eggs. And then the negative binomial parameter K varies inversely with the degree of worm aggregation in the human population. So as the degree of worm aggregation increases, you can see the parameter K decreases. And the intensity of egg in arm 3 is very high, which was implementing school-based MDA compared to the other arms implementing community-wide MDA. This slide shows the patterns of mean intensity of Ascaris by age group and by arms. The intensity of egg decreased in all arms. There is a significant decrease you can see in arm 1 and arm 2. I already know that. In arm 1 and arm 2. And then the decrease in arm 3 is, there is a decrease, but to a lesser extent. And there is a notable decrease in adolescent group. You can see probably this is related to the deworming happening in that area for long years, because deworming started even before Geshiyaro. So this is a slide about the pattern of schistosomiasis in Geshiyaro. So here we have used 2 diagnostics to measure schistosomiasis. One is KK and the other is POC-CCA. When measured by KK, there is a very low prevalence of schistosomiasis. When measured by POC, there is a mixed transmission, but very high transmission. And then there is a significant reduction, as you can see, in arm 1 and arm 2 when measured by POC-CCA. But in arm 1 pilot and in arm 3, there was a reduction initially, then there was an increase. So this is probably related to the mistreatment due to shortage of MDA, and then there may be also the effect of COVID in this. But in this slide, you can see a very notable difference between the KK and POC-CCA diagnostics. So as a summary, Ascaris was a dominant species, as you have seen, and then the most common, the infection rate was very high among the younger age groups, and predominantly there was light infection, but in arm 3, there is a moderate infection, about 2.8%, surpassing the WHO elimination threshold. And then, as you have seen that the schisto and STH prevalence and intensity decreased in all arms with community-wide MD, but to a lesser extent in the school-based MD. Then the distribution of schisto was very high, measured by KK, but low, measured by KK, but very high when measured by POC-CCA, indicating the need for improved diagnostics in the future for monitoring and evaluation. And then the spatial distribution of schisto exhibited also much heterogeneity. In some area there is a very small prevalence, but in the other area there is a very high prevalence, and suggesting that the need for targeted intervention in localized hotspot using effective diagnostic method. So the major limitation in this is the difference in the implementation period, as I have indicated. So for ARM1 pilot, there was implementation for 4 years, then 3 years, then it reduced for ARMS 3. So this duration, I think, has clearly played a role in the patterns observed. And then MDA interruption were also interrupted by COVID pandemic in the all arms. In addition to that, in ARMS 3, the implementation started very late due to remapping of schistosomiasis and soil-transmitted helminths. So that could contribute to the difference in the effectiveness. So in conclusion, the MDA intervention to the whole community or just to the school-age children, combined with some form of wash improvement, led to the reduction of STH infection within the Geshiyaro study communities. As you have seen also, there was a little change observed in terms of schistosomiasis infection, but highlighted the need for improved diagnostics. And then we have seen a community-wide MDA compared with only school-based treatment had the greatest impact, but this requires, I think, more funding for drug, and it needs also cost-effectiveness study to say that community-based, community-wide MDA is much better than a school-based MDA. But the initial results show this is better than the school-based intervention. So that's my presentation. If you have any question, I would be happy to address it later.
Thank you so much, Burhan. Thank you so much. And obviously at the last, there is hope. Yeah, we are going in the right direction. So our hypothesis is hopefully holding up, is what Burhan is saying. So thank you very much, Burhan. We have one last presentation. As you know, in this kind of mass drug administration, individuals have different behaviors. Some of them swallow, some of them turn up, but they don't actually take it, and all of that, yeah? So to explain that kind of intriguing data sets, our Rosie from Imperial College, she explored it, and she will going to present this to us. It will be an interesting insight, hopefully. So Rosie, over to you. You have 10 minutes.
Hiya, my name's Rosie from Imperial, as Maritab said. So I will be talking about the behavioural patterns at MDA in the Geshiyaro project. So to begin with, I think we all know there are many heterogeneities in STH transmission and control. And as we get to low prevalence areas such as the ones we see in the Geshiyaro project, it is even more important to identify these heterogeneities so we can A, identify the hotspots of transmission, and B, then identify areas for improved control interventions. So this is just a sample of some of the many heterogeneities. There are some well-known, there are some less well-known. So you have the aggregation of worms, as Burhan mentioned, the negative binomial distribution within the community, different age dependencies of different species, even different, for the same drug, different species are treated to different efficacies. But some of the less well-known heterogeneities include predisposition to infection. One of our colleagues has shown that some of our participants are predisposed to high-intensity ascaris infection. But like I said today, I will talk about the different behavioural patterns in the community and how this impacts the probability of elimination in the future. So, like everyone has mentioned, we work in Walaita in Southern Ethiopia, but the thing I'll highlight here is that 80% of our population are verified by a biometric, and this gives us a really powerful asset for analysis, where we can look at our denominator and our numerator in real time to analyse such epidemiological measurements such as compliance year on year in a live data set. And this population totals just over 54,000 participants, and I'll be reporting data on 6 rounds of MDA. So the population I am reporting on is a longitudinal data set. So this is the population that have been present from the beginning of the project through to the present. And these are people that have been present from baseline that are also eligible. So for example, if a woman was pregnant in year 3, she would be removed from this analysis. This is different from dynamically analysing at every year point in a dynamic population. That would be a cross-sectional study. So just one more brief thing, to look at individual longitudinal compliance. This can be defined on a large scale between systematically behaving population or a randomly behaving population. A systematically behaving population is defined by an individual's treatment behaviour at time point X, is completely dependent on their treatment behavior at the time point x minus 1. So this is demonstrated in the bottom panel where someone rejects treatment every time or accepts treatment every time. At the other end of the scale is a randomly behaving population whereby your individual treatment behavior at time point x is completely independent of the treatment behavior at time point x minus 1. And this is demonstrated in the top panel. So for our project, well, for any project, having a systematically behaving population is least favorable, as you will generate a reservoir of infection. If you see in the bottom panel, say 30% are never treated, this will generate a reservoir of infection which can go on to reinfect those who are treated, as we know that infection with STH or treatment does not confer immunity. So we would like to see a randomly behaving population, as at least that reservoir has had a chance to be treated at least once. So what does our data look like? Like I said, we have the distributions of behavior. On the far right, you can see a systematic behaving population, or something that could be expected. This is looking at a 50-50, never treated or always treated. And sorry, this is the frequency of treatments from between 0 to 6 rounds. How many times did you swallow treatment? So it doesn't match the systematic. On the left-hand side, you can see the random distribution, or the expected positive binomial distribution from the population. And our data in blue does fit that a little bit better, but we do see more people are treated at all 6 rounds than would be expected from a random distribution. And so what we see in the yellow is what would be expected from a beta binomial distribution or frequency distribution, or treatment frequency, sorry. And so what is the importance of looking at this distribution? It means once we have defined this, we can then look to the future to see what is our probability of elimination based on the current patterns that we see in our data set. Before I go on to look at that, I just wanted to highlight one of the stratifications we have due to our biometric data is our age stratification. And if you look at the different treatment frequency at different age categories, you can start to pull apart some trends. For example, the pre-SAC and adolescents were more likely to be found in the 0 to 4 number of treatments swallowed, compared to the adults, young adults, and school-age children, which were more likely to be found in the treatment frequency 5 and 6, which is treatment at all rounds or the majority of rounds of treatment. So, like I said, we want to look to the future. What is our probability of elimination? Using an individual-based stochastic model of ascaris transmission, we have modeled these 3 different distributions. And we're looking at ascaris transmission as this is our most prevalent species, like Burhan mentioned earlier. We also assume a compliance of 72.8% because in our longitudinal community, or longitudinal data set, this is the average compliance over the last 6 rounds, and we will project this forward to the final 5 rounds of MDA. And you can really easily see the difference that from the same starting point that these 3 different behaviors have in our communities. Like I mentioned, the orange is a systematically behaving population, and that is least favorable because you have that reservoir of infection which goes on to reinfect others in the community. Our data is in the blue, which has a 50.4% probability of elimination, and then at the top you can see a positive binomial distribution or random distribution of compliance within a community. So hopefully this can just briefly outline the importance of looking at your individual longitudinal compliance in your population and how, from the same starting point, how that can affect your probability of elimination in the future. I have shown longitudinal compliance over time, but I just want to briefly look at compliance at just one point in time and looking at the different spatial scales in which that's evaluated at. So on the far left, for just one time point, we have the coverage from these 5 districts within Wolaita. You can see that there is a lot of heterogeneity, and in some, well, 2 kabeles here, there is a coverage between 40 and 50 and 50 to 60% here. This, each sort of shape here is a kabele, which sort of varies between 2,000 to 10,000 people. If you then look at the same data, but against the WHO target, which is above and below 75%, you lose quite a bit of that heterogeneity, but we can still see some areas that need improvement. When you then evaluate this at the admin level 3, which is the implementation unit used within Ethiopia, you lose all of that heterogeneity. And so if this was to be used to evaluate our program, we wouldn't be able to identify these areas. So this map here looks at our school-age children coverage, and this is for our preschool-age children. So it shows a very similar story. Now, finally, this is work done by our colleague Benjamin Collier from Imperial, and he has shown that if you fail to take into account population movement, this can be the difference in predicting elimination or not. And this is the first time that population movement has been modelled for the STH. This is data taken not from Geshiyaro, but from Tumikia in Kenya. And the panel here from A, B, and C shows the prevalence at baseline, after 8 years of biannual MDA, and then finally in C, 10 years after MDA cessation. The difference between the top and the bottom panel is a difference between taking into account population movement. And you can see in the bottom panel, we have a recrudescence of infection, whereas in the top, you don't see that. So you appear to have reached elimination when in fact that might not be the case. So to sum up, I hope I have shown the importance of looking at individual longitudinal characteristics within a population, how that can be so important to spend that bit of extra money on M&E, especially in a situation where we have low prevalence. We reached an average compliance of 72, let's call it 73%, which is just shy of the WHO target. But now that, and we had a very low starting baseline prevalence of 18% of Ascaris. But we still have a probability of elimination of 50%. So that shows that even though we have the good starting blocks, there is still more to learn about our community and that we can also target in the future. For example, I have pulled apart some of the age stratifications that we have, and we can use this to target improved MDA structures in the future. And I guess finally, the spatial heterogeneity of compliance is also important, again, highlighting the need for fine-scale M&E, and just a take-home message that spatial units, even if evaluated at the right scale, are not a static entity, and the population movement should be also taken into account. So thank you very much.
Yeah, thank you so much, Rosie. So we are going to make a deal because we need to discuss some of the questions, obviously. Yeah? So I'm sure a number of you have some views as well. So the reason why we had to present in a row is because we have online viewers as well. So it's because of that. So I think I would like us to reduce our break by 15 minutes. So we're going to spend the next 10 minutes just discussions, briefly, some quick comments or questions so that we can keep them. And then there is a subgroup after that, and we will also show you some video about Geshiyaro. So all of this is coming up. To lead these discussions, at least receive the comments and questions, I have invited Dr. Garama from EPHI. Over to you for the discussion.
Thank you very much, Dr. Mretaab. It is my pleasure to be here to collect the questions and comments. My name is Dr. Garamo Taso. I am currently Director for Bacteria, Parasitic and Zoonotic Research Directorate at Ethiopian Public Health Institute. When I see the number of presentation was about 8 presentations has been presented. When I divided my time, I am in a deficit of time. So I'm going to minimize the number of questions, burning questions, unless otherwise there are a great ample of opportunities to discuss with the presenters outside of the hall during the tea or coffee break, and also tomorrow. Saying this, I would like to give 5 questions for 5, and each just direct, not giving to elaborate the questions. Direct 1. Number 1. Then number 2, 3, 4, 5. So number 1.
Thank you, Dr. Garma. I think my question is on the last presentation, what was just presented. We know that MDA is the mainstay for most entities, and
Direct question.
Yeah, the last slide. Oh, sorry. Yeah, my question on the last slide, which Rosie has presented, is that with 72 point some odd numbers of coverage, elimination has a probability of 50.4. But what does it mean for interrupting transmission? Because Geshiyaro project aims for interruption of transmission. So what is the probability of achieving transmission break for schistosomiasis and STH?
Thank you. Number 2, please, presenters, note your questions.
Thank you, Anthony Solomon from WHO. My question is also for Rosie. were you making an argument for routine measurement of those parameters that you mentioned, or is that just needed for the research context?
Your question goes to number one, which presenter?
Rosie. Yeah.
Rose, okay.
Who is number 3? Oh, sorry.
I just want to know what was the force of this transmission in all the settings you was targeting in your study, and how the randomization process has been done. Because I'm not sure that the force of the transmission was the same in all the locations you was investigating at the baseline. That can compromise a lot of things in your analysis. If we can clarify that, that's good also for us. The second thing is...
only one.
Okay.
Yeah. So.
Okay. Okay, good. 4. Who was 4?
Thank you very much. It's a very interesting presentation. My question is, this is a pilot project, and the whole idea is now to demonstrate interruption of schisto and STH transmission. And by so doing, the whole idea is now to replicate this experience and scale up to other parts of the country. So now my question is, from the experience thus far, is it really a replicable experience? How do you look at that? Thank you.
Very nice, thank you.
Number 5?
Number 5, and the last.
Thank you very much for the very good presentation. Sami Njenga from Cambridge, Nairobi. My question is to Fikri. It was clear that the two methods of drug distribution, the MDA distribution, the fixed point and house-to-house was more, it was better in terms of coverage. But I got about the estimated households that you can cover in the rural area, 25, I think, or thereabout. But I didn't get it for the urban area. What is your experience for the urban areas? Thank you.
Thank you very much. Congratulating all the presenters for the very nice presentation, which starts from the program to evaluation and implementation and evaluation. So it is the whole team, including Imperial College, and the huge acknowledgement goes to the funder, the CIF. Thanks to Dr. Miratab for giving us a chance to give us this opportunity. Saying this, I would like to request presenters to respond to the raised questions. Number 1, to Rosie.
Okay. 30 seconds or 1 minute, yeah?
Yeah.
To answer to the point.
Did you want to answer?
Answer yours.
Okay, sure. So Burhan would like to answer that first question, but thank you very much. It's a great question. I will take the second one, and then I'll pass it back to Burhan. So I think your question was, would you want to see these indicators measured for all programs routinely? I think I understand that we are in an amazing opportunity to have this ability to measure this. I would say maybe when you do reach transmission break settings, these are important, but it doesn't have to be 600,000 people like we have here. It could just be a subsample of the population. But I think the data that you do get from that is incredibly valuable in terms of finding these small trends. It doesn't have to be longitudinal, individual longitudinal to compliance. Potentially you could do a retrospective questionnaire and ask someone, how many times have you been treated? This could be a lesser cost way to get this information, but again, you would have desirability bias and recall bias. But I guess I would say yes, it would be a great thing to have, but I'm realistic and I understand that that's not always possible with the funds that we do have. Thank you.
Thank you so much. I think, Doctor, I have to start from Dr. Teshoba. He has asked a very important question, how to replicate this experience. So this is a project ongoing. We are still documenting the results, so 2 more years remaining. I hope it will be used by the other world affected by the disease. So we are in the process of documenting this thing to share with the wider stakeholder. So the other thing, the other question raised in relation to the compliance. I think compliance is very important for transmission break. If there are systematic non-compliance, then that means we will have a reservoir. So that means recurrence and reinfection after stopping MDA. So it's important to identify systematic non-complier and design a strategy to address them. So this is very important for Geshiyaro and transmission break. Thank you.
Thank you very much. To Fikre.
Okay, thanks so much. So if I really got your question, the question is the household estimate that should be covered each day. So ideally, the idea is first you have to identify, you have to determine the number of days which will be allotted for that particular MDA. Let's say in most of the experiences for this project, the MDA takes about 2 weeks for this, especially for the biometric supported areas. But whereas non-biometric MDA like trachoma and other MDAs, school-based MDAs, the MDA day is as short as a week. So depending on the number of days you allotted for the MDA, you have to estimate the number of households to be covered every day by a single MDA team. And it depends on the number of MDA distribution team. So I mentioned that number as an example. For example, in that particular project, the number of households to be covered a day, within a day, ranges 25 to 150 in areas where the households are very scattered and if there is no road access and so on. You will reduce the number of households to be, and number of people to be covered a day. So you have to consider all those factors to determine how many people to be reached every day. And you have to determine also the number of teams that are deployed for the entire MDA.
Finally, I would like to thank you, all of you, for asking questions.
So each group will have 5 minutes for presentation. No, let us start from group 1. 5 minutes for each group presentation. You want to come here?
Yes, it is.
Hello. Oh, goodness. Okay. So the first question that we spoke about was what fraction of the total NTD control program budget should be assigned to M&E. We worked sort of based off of original WHO recommendation of 10% and sort of all indicated that that wasn't sufficient. And so some of the things that we considered were around endemicity and also just in terms of the course of the program, sort of the further you get along, hopefully the lower prevalence is. You likely need to spend more on M&E and less on treatment. We have a little range of 10 to 20%, but sort of not tied to those numbers. In terms of our second question on sentinel sites for longitudinal monitoring, and if that is an essential part of M&E, there was sort of a unanimous vote that they were essential but not sufficient. And one of the things that was discussed was sort of complementing longitudinal sentinel sites with random or pseudo-random considering risk, cross-sectional surveys. And we spoke a little bit about potential bias, but also fatigue in terms of longitudinal monitoring. And the last question that we spoke about was around as prevalence of infection falls, should more sensitive diagnostics be used for M&E? Again, the group was all in favor, but also noting that specificity was also important, and that likely what would need to be considered is still maintaining some of those classic diagnostics, not only relying on new diagnostics, both in terms of cost, but also comparing to previous data that was collected. not directly related to this, but one of the themes that did come out was around the cross-cutting implication of data quality and digitization, that at the end of the day, you need to trust data. And so that sort of underscores everything that's within that, not just sensitive diagnostics. We had an extra question that was given because I don't think Group 4 formed, and it was what should be done to enhance the control of strongyloides infection, which are common throughout STH endemic regions, and what is the drug of choice? This was very quick, sort of done in our last 30 seconds, and we came up with a need for better diagnostics and testing of combination therapy being albendazole and ivermectin, and I believe the STOP trial, if I have my acronym correct, was something we were all interested in the results of.
Thank you so much. Now group 2.
I was promised that I'd just have to email them. Could I have a look at the actual questions?
It's the one that's folded right there.
Thank you. Right, so are biometrics an important component of M&E? Overall, we felt yes, that they are, and they are sustainable, and it gives us a really nice kind of way of tracking everything. So very positive answer there. What spatial unit would be used? Overall, we went for village for schisto, and then kind of the slightly larger district level for STH, which is a lot less variable. Then when should we stop MDA for schistosomiasis and STH? As best as I could, I scribbled down quite a lot of different things, but there was quite a bit of discussion there. Overall, one of the points that did get raised is that there is a need for clearer guidance, multi-stakeholder agreement on that. Did I miss something? Please. Yeah, just keep going. Yeah. Yeah, I think that's us. Thank you.
Now the final group, group 3.
Thank you. So our question was around MDA intervention strategies. What kind of variation should we utilize for STH species, considering drug efficacy, and how should this influence intervention design? And so we talked about really starting with a parasite-specific strategy, where appropriate, adding another drug. So we talked about the example of trichuris and doing combination treatment, and then ensuring that there are efficacy studies included for monitoring purposes. And just, yeah, in the request, ensuring we're thinking about hookworm versus ascaris and what drugs, recognizing that many of the programs get a combination of albendazole and mebendazole. Should MDA be extended beyond school-age children? So this was, the consensus overall was measure prevalence. We need focalized results, so based on reassessment surveys, consider moving beyond school-age children, but also dependent on the resources available, both for donated drug and for distribution. So the importance of countries coming up with a prioritization system, depending on the situation. And how should treatment frequency alter? Again, for STH and schisto as prevalence falls, again, survey results. I think the subsequent question was kind of tied to this. What should be done once a program achieves elimination as a public health problem? And we said there needs to be more guidance around that prevention, of course, is critical, and surveillance systems, but knowing exactly how to alter based on EPHP, more is needed in that area. I don't know if my team wants to add anything. Jeshome, Fikre, anyone else? Huh? Yeah? No?
Thank you so much. I would like to thank all of you for delivering that assignment within a very short time. Now I will call Dr. Meret to the podium to give us a closing remark.
Hello, test. Yeah, thank you very much. I don't think I have a lot to say. Obviously, I've been talking non-stop. Except to say that, huge thank you for everybody who contributed in this session. As you heard, I think Geshiyaro is an ambitious project that us and the other donors, WHO, and also most importantly the Ethiopian government discussed back in 2017-18 whether it's possible. And there were a number of reasons, context or developments in the background at that time, including the manufacturers, the drug donation. Like we can't forever provide drugs, mass drug administration, it's for free. So when do we end this? We can't keep, there is no free thing, yeah? So I think all of these conversations at that time were quite important in terms of the NTD world, especially on STH, SCH, to show that, well, there is an end, hopefully, at some point. But to define that end, we needed to have evidence. So from Gates Foundation side, I think they started the D-worms 3, as you know, a trial. But in Geshiyaro, we needed to do the community-based one in real life situation where the government is actually implementing and so on. So I think here we are now, 5 years later. I'm standing here, I can't say we have the answer to tell whether the end is clear or not. But I hope from all the beautiful presentations you have seen from colleagues, we see some indication. I personally feel we are better now compared to where we were in 2018-19 when we first thought about this kind of thing, like how do we define? In fact, the challenge now, in my view, and I was talking to colleagues earlier in the tea break as well, including with WHO and so on, is we have similar things in India as well, C-funded projects. So actually, the prevalence may come down, and we may see hope for transmission break. But what does that mean? At what point do we actually stop, like in Geshiyaro, when do we celebrate? Saying, yeah, we managed to break transmission. Can anybody ever say that? Big question mark, yeah? And if we do, on what basis? What is it? Just prevalence coming under 2. Imagine somebody goes there and does the sample and, well, in this district it's 20%. What are you talking about? You didn't manage to achieve, yeah? So it's still yet to be defined, okay? So I think that's the next challenge which we are discussing with WHO and other donors, partners as well, because WHO doesn't have the answer. There is no guideline, there is nothing what to do next, okay? So yes, the modeling helps us to go to under to prevalence and so on, but in most villages, once we get there, what does that mean? So hopefully in the future, we are trying to organize some kind of intellectual workshop, something globally with our India team colleagues as well, governments, WHO as well. So hopefully we may try to put something to guide governments. It's their decision, obviously, to guide governments in terms of deciding, but also the donations, because there has to be at the end at some point. So it will hopefully inform that as well in terms of when to stop these things. So all the contributions today have been very useful. So I just want to thank once again everybody who contributed. Partners, obviously, in Geshiyaro from the beginning. First, the Federal Ministry of Health. I mentioned the ministry, all the series of ministers we had over the years have been very influential in this project. So thank you to everybody. Well Vision, Simprints, Imperial College, particularly Professor Sir Roy Anderson, who is the mastermind, by the way, behind everything we do here technically. I come and talk about it, but he is always, so he couldn't be here today, but huge thank you to Roy Anderson as well, and everybody else who contributed, individuals who presented here, and then the organizers, of course. And finally, I would like to thank the technical team as well there, who managed to do all this virtual, hundreds of people watching us live. So thank you so much. Hats off to you all. So with that, just final request, if you can scan this QR code to give us some comments on the whole event, that would be useful. And thank you so much for being here, and hopefully you will have better sessions and best sessions again. in the next few days on COR-NTD, also in terms of the STH, the other conference that's coming up as well. Thank you very much. Have a good evening.